Okay. Good afternoon, everybody, ladies and gentlemen. Thank you for the MC, Ms. Mui. First, I would like to give my respect to Dr. Sopian as a chairman in this session. Also, my respect to Mr. Kakada and Mr. Vesna. Thank you also for Dexa Medica for inviting me to share my opinion in this very excellent session. Also, let me to give my warm greeting from Indonesia for all of my colleagues in Cambodia, and I'm very happy to joining you today. Today I will give a brief review regarding the role of Etoricoxib in rheumatic pain. Let me prepare my slide. Okay. Okay. I hope my slide already in. Okay. This is my topic today. I think we are here all already familiar with the use of NSAID in our daily practice, in outpatient or inpatient setting. But today, I will focus my talk only in the role of Etoricoxib in the treatment of arthritis pain. Actually, I prefer to come directly to Cambodia because I want to see a lot of beautiful temple and beautiful culture also in Cambodia. But maybe next time I will come to your country because I love to come in this country, especially for the food. This is my activity actually. I have a great concern in doing several clinical trials, multi-center international, in specific areas such as gouty arthritis, rheumatoid patient, and also in lupus. And currently ongoing is my research in belimumab in lupus patient. Recently, I participated in the APLAR working group to develop the first guideline for rheumatoid arthritis patient. And I also acknowledge here my activity to give some lecture or talk invited by other pharmaceutical company. This is where I am now in my place. I live in a small city in east of Java. The city was called Malang. It is near the Bromo mountain. Maybe you more know about the Bromo mountain. And this is my workplace, the government hospital, Saiful Anwar. And this is my university, the Brawijaya University, because my basis activity as a staff, medical staff, and also as a lecturer. This is my latest participation in the APLAR. We have, it was very interesting experience for me to join the APLAR group to develop the Asia Pacific recommendation for rheumatoid arthritis patient. Before I start my presentation, I would like to remind all of you that in our daily practice, we frequently have patients complaining with pain. And it was reported more than 50% of our patient problem are chronic pain, mainly in musculoskeletal disease and rheumatology area. And we also know that we use a lot of NSAID to treat our patient with inflammation. For example, in osteoarthritis, in rheumatoid patient, and ankylosing spondylitis, and also other rheumatic disease. Some of the disease I will review later in my slide. The other problem is about the issue of prolonged using of NSAIDs. The issue is about the GI tract problem and also renal and vascular problem. So I will review about the role of Etoricoxib in this condition. This is about the pain. It's very familiar in our practice. Mostly the patient come to our practice with pain, headache, back pain, joint pain, and everything. Yeah, and we know that the spectrum of pain is very wide because any condition causing unpleasant sensory in our life could be considered as pain. And the pain in rheumatology, in musculoskeletal disease, mostly associate with tissue damage or tissue inflammation. Maybe in some area we do not found a clear tissue inflammation or tissue damage, but in our area in musculoskeletal disease, mostly the patient will have tissue damage. So that's the definition of pain we already used for years. And these are the type of pain that mainly affect our patients. Yeah, patients with rheumatic disease mainly have this type of pain. We call it nociceptive inflammatory pain because we can see here in this picture, the inflammation process will produce several substances such as prostaglandin, bradykinin, thromboxane, and also substance P, which will stimulate the nerve ending and then will be considered develop pain. So in our patient, in musculoskeletal disease, in rheumatology disease, we will observe directly the presence of sign of inflammation in the area of the patient. For example, joint pain or soft tissue pain, tendon pain, they will have this condition. So that's why mostly we're facing inflammatory pain. But in some condition, some of our patients also have different type of pain. For example, neuropathic pain. Frequently in patients with low back pain, also will mention about sensation of neuropathic pain. The mechanism is quite different because in this condition, we do not have a very clear of sign of inflammation such as before, because there is no sign of redness in the area of the pain. There is no sign of swelling. There is no sign of a redness or warm in the area of the pain, but the patient complaining in that area pain. So mostly in our clinical practice, we will have both or maybe more condition. So there is a concept that's called mixed pain. Might be our patient will have mix between inflammatory pain and also other type of pain because the treatment will be different. This is a survey, quite interesting, in 2010, 2006 in Europe. They report that the use of NSAID are very frequent. This is the answer from the respondent. Almost 50% of the patient experience of prescribing NSAID from their physician. So NSAID is a very frequent drug used in clinical practice, and then followed by others medicines such as opioid, paracetamol, and also COX-2 inhibitor and others. So back to the previous description, that we have a lot of patients with inflammatory pain. That is underlie why we prescribe or the patient prescribe with NSAID also a lot. I would like to, I think we all know already, familiar with this diagram, with the graphic, that in inflammation, this path will activated. Yeah. If there is stimulation in the joint, there is activation of cyclooxygenase 2 enzyme, which will produce several type of prostaglandin, will develop a sign of inflammation. But the other side, the constitutive COX-1, it is present in normal condition, have a very important function to maintain our important organs such as stomach, kidney, and also the thrombocyte. So this is in a normal condition. And we know that traditional NSAID will block both of these sides. So that's why traditional NSAID will alter other system normal physiologic function, because actually in inflammation we need to suppress this COX-2. So we can preserve the COX-1, but we can suppress the inflammation through this mechanism. So that's why the concept of COX-2 inhibitor developed in order to control the inflammation by preserve the other normal function. This is about the Etoricoxib. This is considered as a COX-2 inhibitor. This is the structure, the chemical structure. I would like to give you information here about the pharmacokinetic profile of several COX-2 inhibitors. In this report, they compare about Lumiracoxib, Celecoxib, Valdecoxib, Rofecoxib, and Etoricoxib. And I just want to highlight here the maximal plasma concentration time here in Etoricoxib is almost 1 hour. And the half-life, the elimination half-life is more than around 22 hours. This is important to know because this is will explain why the onset of Etoricoxib is very rapid, because the time to maximal plasma is only in 1 hour, and the duration of action also will prolong, lasting until 24 hours, because the elimination half-life is around 24 hours. This will give different action, the Etoricoxib with other COX inhibitors. This is an interesting study based on the previous information. In clinical study, they show that the action of Etoricoxib is very rapid, around 24 minutes. They put here the patient in several doses of Etoricoxib, start from 60 milligram, and then 122 milligram, 180 milligram, and the maximal is until 250 milligram. And we can see here the efficacy, the pain relief effect of different doses. We can see here from dose of 60 milligram, the effect will increase until the dose of 120 and 180 milligram. But then after the dose above 180, the efficacy will slightly decrease. So based on this graphic, we consider that the most effective dose is around 120 milligram for relief to maximal pain relief. And also the onset here is very rapid. Compared to ibuprofen, looks more longer to develop the onset, but the Etoricoxib appear within the first hours. Now I go into the several conditions in our practice. The first is about acute arthritis pain. What is the diagnosis that frequent associated with acute arthritis pains? There are several conditions, but I think the most typical condition is for gouty arthritis, because we know that in a patient with gouty attack, the pain can develop very rapid in few hours, because the maximal pain can develop in less than 24 hours. So this is a very good example, I think, to show acute pain in rheumatology. Why that condition can happen? Because the presence of crystal within the joint can develop very rapid inflammation through several mechanisms. Maybe the direct stimulation of the crystal to the immune cell, or might be with effect to the activation of other inflammatory cells. So this is a good example for an acute pain in rheumatology. How we treat this condition? I believe all of you already treat this patient. We have several options to treat flare of gouty arthritis. In the past, we start to use colchicine at the first line treatment, and then the evidence show that NSAID and colchicine give similar effect. So we have option to use colchicine. We also have option to give NSAID or COX-2 inhibitor, or maybe steroid orally or locally to treat gouty arthritis. And we already practiced this for years, since a long time ago. Now I would like to show what are the recommendations recently. This is just published maybe few months ago by the American College of Rheumatology, the guideline 2020 for management of gout. They clearly mention here that in patients with gout flare, we strongly recommend using of colchicine, NSAID, or steroid. So there is not a big difference with others' recommendation. We still have a good option to use colchicine, NSAID, or glucocorticoid as the first line, depend on the patient condition. Because before we already start with colchicine at the first line treatment, but now it's similar whether you use NSAID, colchicine, or steroid at the first line treatment. There are the new the other new issue I would not review here in this, because you can read here directly to the guideline. How about the study in gouty arthritis for Etoricoxib? This is a study from Michael Schumacher, I think, in year 2002. They compare the use of Etoricoxib compared to indomethacin. We know that in the past, indomethacin is the option, the preferable NSAID to use in gouty arthritis. But next, we can use any type of NSAID. So in this study, we can see here the effect, the pain score is significantly decreased in both groups, and it is not different between Etoricoxib and indomethacin. They use the dose of Etoricoxib 120 milligram compared to indomethacin 150 milligram. In Indonesia, it's not frequent to use indomethacin, because only 1 or 2 products available in Indonesia, but we use with other NSAIDs. And we can see here the safety of Etoricoxib and indomethacin. The drug-related clinical adverse experiences is more frequent in indomethacin compared to Etoricoxib. So in this study, we can see that Etoricoxib have similar efficacy in terms of pain relief in gouty arthritis and have better safety. How about in chronic conditions? We have a lot of diagnosis with chronic pain in our rheumatic patients. I would like to give you the first example is about osteoarthritis. It is a very common disease in our community, and the diagnosis is very simple actually, just by history taking and then simple examination and simple radiograph, we can define our patient with OA patient. But we have to remember that the spectrum of OA is very wide, not only knee joint, but may also can involve the small joint such as in hand OA. How we treat this patient? The diagnosis is simple, but actually the pain is quite complicated because there are several mechanisms in patient with OA. For example, here the pain may develop in several sources, such as this is the main source we know. It is the synovitis, inflammation of the synovium, and then might be also developed from the periosteum by the osteophyte, also the bone pain sensation, deep pain from the bone, and also the neuropathic mechanism. So actually the pain in OA is not simple, but we agree that the main mechanism is the inflammation of the synovium. The other issue is the pain in OA is not a peripheral mechanism. This hypothesis, this review mentioned that the possible of the central source of the pain in OA patient. So that's why in OA patient, they have lower pain threshold compared to normal person. So that's why the pain on OA not only peripheral mechanism, but might be a central mechanism play role in the pain of OA patient. How we treat now the pain in OA patients? I back to the recommendation by the Euler. I think they still valid. There is a new recommendation from the ACR for the OA, but I show here the Euler recommendation because it's easy to catch here that NSAID, including COX-2 inhibitor, have an important role. Yes. After we follow the recommendation, start from the non-pharmacologic treatment, for example, education, body weight control, mechanical problem, and then we can give acetaminophen, a simple analgesic, and then we can go to the NSAID if the pain still exists. And the top of the triangle is a surgical approach. So in general, we can see here that NSAID have an important role in the treatment of pain in patients with OA. This is the study of Etoricoxib in OA patient. I just put here one graphic. Actually, there are several results from this study, but I just want to show here Etoricoxib with dose 60 milligram compared to diclofenac 3 times daily, 50 milligram. We can see here that the effect, the onset is more rapid in Etoricoxib compared to diclofenac. And then after the dose stable, we can see here the pain, the decline of pain level is similar between the Etoricoxib and diclofenac. And they observed the study until 52 weeks. This is also an interesting study comparing the Etoricoxib 30 milligram with Celecoxib 200 milligram. this study for Bingham in 2007. They show that in OA patient, Etoricoxib 30 milligram is the same efficacy with Celecoxib 200 milligram. We can see here the graphic is not statistically significant. So it is Etoricoxib 30 milligram, it's non-inferior to Celecoxib 200 milligram. This is in different condition in rheumatoid arthritis patient. Do we still have, do we still need NSAID in rheumatoid patient? Because this is different condition. This is an autoimmune disease. So we need to suppress the immune process because they will result in severe deformity of the joint. This is the 2019 recommendation from Euler, just a few months ago, published. They divided the step into 3 phases, and we can see here the phase 1. Since the diagnosis confirmed, so we have to start to treat our patient with methotrexate or other DMARDs, with or without steroid. So from this diagram, we do not see the place of NSAID here, because as we diagnose our patient with rheumatoid patient, we have to start methotrexate. So they do not mention anymore the role of NSAID in rheumatoid arthritis patient in the recent recommendation. But it's quite different in our recommendation in Asia Pacific. This is the 2015 and already updated in 2018. But we still need to mention here the role of NSAID, although it's very limited place here to put our patient in NSAID. Why? Because before we start methotrexate or other DMARD, we have to make a good screening to our patient. Maybe this is still need a few times to wait the result to define the condition before we start the DMARD. So that's why we still possible here to give our patient with NSAID only in very limited indication, because we have to put then our patient with methotrexate or with other DMARD or maybe biologic agent. So that's, I think, practical for us to still the reason, or although very limited, to use NSAID in RA patient. This is the study of Etoricoxib in rheumatoid patient. This study was reported in 2002 by Matsumoto in rheumatoid patient already treated with methotrexate, some of them, and also maybe with steroid, and then still having pain, and then they put with Etoricoxib or naproxen. There are 2 data from the US population and from the international data. We can see here that Etoricoxib 90 milligram compared to naproxen 1000 milligram with placebo, clearly here shown that the Etoricoxib 90 milligram have better effect in rheumatoid patient in terms of tender joint count. Also in international data quite different, but they show here the effect of Etoricoxib and naproxen similar. So anyway, Etoricoxib still have a role in combination with other DMARD to treat our patient with rheumatoid arthritis. How about in Ankylosing Spondylitis? This is a patient with autoimmune disease also, with main complaint in the back, and we can see here the sacroiliitis with both sides, and then a patient with enthesitis. So diagnosis is clear, the Ankylosing Spondylitis. And then how we treat this patient? This is from the ASAS and Euler recommendation 2006. We already used this for a long time. They mention here NSAID is the first line treatment for patients with ankylosing spondylitis. And then we divide the patient into axial or peripheral. In peripheral condition, we still have chance to give DMARD sulfasalazine here. And then the last option is using of biologic agent. Let us update this recommendation. This is a study quite a long time ago, 2006. Just I want to show you the effect of NSAID in AS is quite different with other disease, because NSAID in ES considered to have a disease-modifying effect, not only work as anti-inflammatory drugs. This is the study to show that continuous NSAID until 2 years will give good in radiographic improvement compared to on-demand NSAIDs. This is only few data to show this, but we still need more data whether this is true that NSAID have a disease-modifying effect. This is the latest recommendation for ankylosing spondylitis 2019 from the American College of Rheumatology with other society. The first line is still NSAID and prefer to give continuous rather than on demand. So they recommend the use of NSAID continuous in patient with ES. But in patient with, this is for patient with axial predominant. But with patient with peripheral spondyloarthritis, if failure to NSAID, we can give the patient with sulfasalazine. If still active, then we go through to the next second line treatment with anti-TNF and other biologic agent. So I just want to show here that NSAID is still important role in patient with ankylosing spondylitis. This is the data for Etoricoxib in ankylosing spondylitis. This is the study comparing Etoricoxib 90 milligram and dose 120 milligram compared to naproxen 1000 milligram. So the data shows here clearly that both doses of Etoricoxib are effective to suppress the pain, the spinal pain compared to the naproxen. They observe until 52 weeks, quite a long study. Now, I would like to review in brief about the safety of Etoricoxib. There are many data about this, but I would like to refer to this study, the MEDAL program. It is the multinational Etoricoxib and diclofenac arthritis long-term study sponsored by the MSD to define the safety of cardiovascular safety and GI tract safety. There are several studies concerning the coxib safety. The celecoxib, they have the class study, and the lumiracoxib, they have the target study, and the Etoricoxib, we have the MEDAL study. And interestingly, the MEDAL study involving very more than 34,000 patients, and the duration of observation is until 40 months with average 18 months. So it's quite a long study and involving a lot of patients compared to the other studies. So what are the main results for this study? I just go to the several results. This is the upper GI safety in MEDAL study. Between Etoricoxib with dose 60 to 90 milligram compared to diclofenac 50 to 75 milligram BID. So the frequency of symptomatic complicated upper GI event is less frequent in patients with Etoricoxib, with hazard ratio 0.69 and significantly different. But in lower and the complicated event is not statistically significant, but anyway, it's lower than diclofenac. How about the cardiovascular study? This very raised a great concern in the use of NSAID recently. I just gave a short result here about the cardiovascular outcome in MEDAL study. The outcome is the confirmed thrombotic cardiovascular event. They observe a lot of patients until more than 3 years, and we can see here the cardiovascular event is not statistically different between Etoricoxib and diclofenac for a long time. Finally, I just want to summarize my presentation that Etoricoxib is effective for acute and chronic pain in rheumatology, and the onset is very rapid within 24 minutes and lasting for 24 hours. Then we also already reviewed together that Etoricoxib provide better GI tract safety with comparable cardiovascular safety when compared to traditional NSAIDs. Thank you very much. And this is one temple in Indonesia. It's quite similar with temple in Cambodia. I also want to invite all of you, maybe sometime come to Indonesia. Thank you very much.